All right, let's talk about something you absolutely positively cannot miss on the wards: infectious arthritis. This is a true medical emergency, and for anyone in training, knowing how to spot it and what to do next is an absolutely critical skill.
So, here's how we're going to break it down. First, we'll cover how to recognize that classic red-hot joint. Then, we'll walk through the diagnostic steps. After that, we'll figure out which bugs are the likely culprits, and finally, we'll nail down the principles of management. It's a really logical flow, from the minute the patient arrives to getting them treated.
Okay, first things first. Let's set the scene. You're faced with a patient who comes in with a single joint that is just screaming in pain. This is where it all begins. So you see this, one joint, usually a knee, that's blown up and incredibly painful. Your brain has to go to one place immediately. Until you can prove it's something else, your number one concern has to be a septic joint.
This presentation usually isn't subtle. We're talking about a joint that is swollen, red, warm, and just exquisitely tender. The patient won't want to move it at all, not on their own, and they certainly won't let you move it. They might have a fever, feel sick all over, the whole shebang. And here's a huge red flag you got to watch out for. If you have a patient with something like rheumatoid arthritis and they suddenly develop one single angry joint, you have to assume it's infected on top of their underlying RA.
Okay, so your alarm bells are ringing. You're thinking this could be a septic joint. What's next? How do we go from just a suspicion to being certain about the diagnosis? It's all about having a system.
It's a pretty straightforward path. Of course, you start with a good history and physical exam. But let me be super clear. Step 2 is the one that matters most. It is the absolute, non-negotiable, game-changing step getting fluid out of that joint. Everything else, like labs and x-rays, is just supportive.
And I'm going to say it again because it is that important. You can order all the blood work and imaging in the world, but the real answer, the money, is in the synovial fluid. You have got to tap that joint, and you've got to do it fast. Do not delay.
So you've got the fluid. Awesome. Now what? You're going to send it for 4 key things. A gram stain, to get a quick look for bugs. A culture to see what grows. A leukocyte or white blood cell count to see just how inflamed it is. And finally, a crystal analysis to see if gout or pseudogout is in the picture.
Okay, if there's one number to remember, it's this one: over 50,000. If that synovial fluid white count comes back over 50K, especially if it's mostly neutrophils, you have to treat it as an infection until proven otherwise, period.
All right, listen up, because this is a classic trap that even experienced docs can fall into. You tap the joint, you see crystals on the microscope, and you think, it's gout. But hold on. You can absolutely have both gout and an infection in the same joint at the same time. The presence of crystals does not mean there's no infection.
And if you need a reason why we're so aggressive about this, look at this image. This is the end game. This is what happens when we're too slow. An x-ray might look totally normal at first, but if you miss the diagnosis, the infection just eats away at the cartilage and bone. We are trying to prevent this from ever happening.
All right, so we've tapped the joint, we've confirmed it's an infection. Now the question is, who's the bad guy? What's the bug we're actually dealing with?
When it comes to the usual suspects in non-gonococcal cases, one group totally runs the show. About 75% of the time, it's going to be a gram-positive coccyx. And the kingpin of that group? Good old Staphylococcus aureus. That's your number one bad guy.
But okay, let's switch gears for a second. The patient's demographic can totally change the game. If you have a younger, sexually active patient coming in with joint issues, your brain has to go straight to Neisseria gonorrhea. This is a huge one to consider in that population.
And this bug is a bit tricky because it can show up in 2 different ways. Think of it as having 2 flavors. You can get this arthritis dermatitis syndrome where you have tendon inflammation, these little skin lesions and aches all over. Or you can just get a straight-up purulent arthritis in 1 or more joints, but usually without all the other stuff.
And check this out. This little skin lesion right here, this is a massive clue. There are these little pustules, often on the hands and feet, and they might not even hurt. If you see one of these on your patient with joint pain, you are one giant step closer to making the diagnosis of disseminated gonococcal infection. Okay, another pivot. Let's talk about Lyme disease. If your patient has been hiking, camping, or lives anywhere with ticks, you gotta have this on your radar. The classic picture is this huge, swollen knee, but weirdly, it might not even hurt that much. The size of the effusion can be really out of proportion to the pain.
Now, here's the key difference with Lyme.
The answer isn't in the joint fluid culture. Instead, you diagnose it with blood tests, using this very specific two-step process. First, a screening test, and if that's positive, you move on to the confirmatory test.
And we can't forget the really high-stakes situation, an infected prosthetic joint, a piece of hardware. The timing matters here. But the ones that should really make you nervous are those delayed infections. They can be caused by less aggressive bugs and can be super subtle, just presenting as a bit of pain or a loose joint.
Okay, we've put the pieces together, we have a diagnosis. Now for the most important part. What are we going to do about it? How do we treat this?
The rule here is simple. Hit it hard and hit it fast. As soon as you've sent your cultures, you start broad IV antibiotics. You do not wait for the culture to come back. And because MRSA is so common, vancomycin is almost always part of that initial attack.
But, and this is a big but, antibiotics are not enough. Think of that infected joint as a bag of pus. It's an abscess, and you have to get the pus out. That means either tapping it with a needle every day to drain it, or calling your friends in orthopedic surgery to take the patient to the OR for a washout. For deep joints like the hip, surgery is almost always the answer.
So let's just recap the big takeaways from management. 4 simple rules. Number 1, culture first, then treat. Number 2, start those broad antibiotics right away. Number 3, drain the pus. And number 4, if there's hardware involved, get a surgeon on the phone early because that prosthetic might have to come out.
And there you have it, our explainer on infectious arthritis. I want to leave you with this final thought to chew on when you're on the wards. We've gone through the algorithm, but how does your patient's story, their age, their immune system, their social history, how does that change this whole approach? Always remember to treat the actual person, not just the joint.